All right, let's get started. I'll be introducing our seminar tonight. Thank you, everybody who's here on Zoom, for coming to our seminar on building on community strengths for mental health, models from Hong Kong and North America. My name is David Bishai. I'm a professor at the University of Hong Kong, the director of the School of Public Health. I'm really excited that we were able to put this webinar together, and I want to give special thanks to the family cohort team at the Hong Kong University, Ms. Kelly Tam and Dr. Michael Nee of Hong Kong University, for helping to organize this event. Michael Nee and his group of the family cohort is working on this problem of population mental health in Hong Kong and globally, so we're so grateful for their support. The genesis of this evening's session comes from my own acquaintance with the Johns Hopkins team and the Center for Indigenous, where our first speaker would come from. And then this summer, I had the privilege of meeting the leadership of Mind.org, who I'll be introducing later, and learn about so much that they're doing. And what struck me was the similarity of really unlocking community capability and relying on the people in the community with the perceived need to do more for mental health. I saw this when I was working with the Johns Hopkins Center, and I see this now in Hong Kong. And I think we really could learn a lot by comparing our notes on this. So what I'll do is our breakdown will be first a presentation from Mary and her work in the Center for Indigenous Health, and then we'll turn it over to our team from Hong Kong. We'll have time for questions and answers starting at about 8:30, so stay tuned for those questions. We'll be able to use raised hands on Zoom as well as the chat box. So first off, I wanted to introduce Dr. Mary Cwik. She is a licensed psychologist and a senior scientist and associate director at the Center for Indigenous Health at the Johns Hopkins School of Public Health. She also has a joint appointment in psychiatry at the Johns Hopkins University School of Medicine. She has a background in psychology and a PhD in child clinical psychology, and a postdoc in Johns Hopkins in the Division of Child and Adolescent Psychiatry. And her research has been in the area of suicide, substance use, trauma for over 15 years. The work we'll be describing tonight is a very exciting project that has been going on in the White Mountain Apache tribe, and I will let her introduce that to you and let you have the floor. Thank you, Mary.
Thanks, David. Good evening, everyone. I'm going to go ahead and start sharing my slide. It's really an honor to be presenting to you guys this evening. I'm really just one member of a large team that's doing this work. All right, let me go ahead and I'll get this going. Looks like you got... All right, if somebody could give me a thumbs up if you guys are seeing the right display, that would be great. Or just tell me. It's a little early here this morning, so hopefully someone will flag me if I'm got the wrong thing up. But
we see nothing yet. We don't see any.
Oh, you don't see it? Oh, that's
nothing
strange.
Sharing.
Nothing sharing. All right. Let's do and show, because I see both. All right. Do you see the slides now, David?
Nothing.
Nothing.
Just our Zoom room.
All right, let's try it again. All right, do you guys see it now?
Yeah, it's coming. And we see a PowerPoint. It's not in presentation mode.
All right, perfect. Let me get it going.
Perfect. There's perfect. That's what we want. Thank you.
Wonderful. I appreciate it. I'm still having my morning coffee. So today I'm hoping to, in the brief time that we have, really just give you a brief highlight of our Center for Indigenous Health, just to give you a context of our history. In addition, I will be really focusing my time on the Celebrating Life program that David mentioned. I'll give you a little bit of background on that and some of the results from that system. In addition, I'll talk to you guys about a current research study that we have that's a randomized trial to really be able to examine the effects and impacts of some parts of that program. And then I will go ahead and end with some summarizing. And I really look forward to the end and all of your questions, because I know we just have a brief time today. And I'll have my contact information on the slides as well, if anyone wants to reach out after today's webinar. So just briefly, it's really important for everyone on the call and the webinar to understand we're located in the East Coast of the United States in Baltimore, Maryland, near Washington, D.C. at the Johns Hopkins School of Public Health. And our tribal partners are located in the southwestern part of the United States. So just to give you a sense, there's a good distance between us. There's flights and 3.5-hour car rides to get to each other. And I'm not going to read all the information on the slide, but the part is, how did that relationship start, right? Because we're talking about community-based participatory work. And it really started with the man on the slide. He lived out on our tribal lands with our tribal partners for many years, and they really trusted him, and he built that relationship. And that's how the center started. So even though we are separated by a lot of distance, we have a lot of travel and close contact, and we really have that trust relationship. That's really the foundation of our work. And we work across multiple domains in addition to suicide prevention. That was actually one of our later domains that the tribe came to us and said they really wanted help with this issue. And as David said, I've been part of this work for about 15 years now. So again, you can see here, just to get a sense, these are all of the different states that we have partnerships and do work. But really where the brown or maroon boxes are, that's really where the heart and most of our programs are. And so the work that I'll be talking about today, I don't know if you'll be able to see my arrow here, but is really this Arizona part of the work. So it's really White River and Fort Apache. That's the work that I'm talking about this evening. So just to give you guys a brief context, again, I'm not going to read through all of this, but there are a lot of health disparities for Indigenous populations in the United States and likely in other parts of the world as well, but these are our US statistics. And so as you can see here, the suicide rate in tribal communities, particularly among young people, is at least 2 to 3 times higher than other populations in the United States. And depending on the tribe, it can be even higher. It is important to note some tribes do have very low suicide rates. So it's there's not a one tribe fits all scenario here. So every tribe is a little bit different and has unique risk factors and protective factors. So it's just important to keep that in mind. So the things I say today, even though they are generalizations, they're not necessarily true of every tribe in the US. So here's just to give you a sense too of some of the cultural strengths that the tribal nations have and that we design our programs around. So elders are really keepers of wisdom. They are really the heart of the community. So we are able to involve them in our program. Native peoples also feel a really strong connection to the land. So that's really important in the work that we do, the connection to place and environment. In addition, they really emphasize what we might call a holistic or multi-component approach to the things that they do. They're not just looking at an individual level. If we think of something like suicide prevention, their context and their knowledge says it would be important to interact with the family, with the community, in addition to just working on individual issues. So again, here's just a little bit about the tribe to give you a sense of the size, because people always want to understand that. It is a smaller population, but the land mass is a decent size. And so that's important to know. They have a tribal council, which has the ability to make laws for that tribe that are different than the US and federal and state laws. So that's an important part of the context as well for our talk today. Something else that's important to know, and these pictures are all from the tribal community, is that what we understand is that there were very low suicide rates prior to 1950. Again, it's hard to know how much of that is just not documented, but it does seem to be fairly accurate, and that in really around the 1990s, they started to see different spikes in suicide among their young people. And that's when the time when they reached out to the Center for Indigenous Health. So just again, to give you a sense, the program that I'm going to talk to you about really took a long time to develop. It was, I guess, really over 30 years if we look back and sort of think about it. And so again, they really went to the folks in the community and the tribal council and went around to different departments to get input on What is the problem? What do we think is causing it? What do we want to do about it? They then implemented a local program called Ghostbusters, which I'm happy to answer questions about later, but that was successful, but only implemented for a small period of time. And then in the 2000s, they did the program that I'm going to talk to you about in most depth, and that is this tribally mandated suicide surveillance system. And what's really unique about it, there are other registries or surveillance systems in the US and in the world, but this was really the first of its kind that wasn't just hospital based. A lot of the early surveillance and registries were really based out of hospital systems, which made sense, right? People who are thinking about suicide and attempting suicide often end up in our hospital system, but there are a group that doesn't end up in the hospital system, and this community-based system has the ability to really pick that up. So again, this mandate, this tribal law that our tribal nations have the ability to enact really requires that anyone who lives or works on the reservation, whether they are native or not, report to a central system if they become aware of someone at risk for suicide. So in particular, the behaviors that they're reporting are listed there. And the thing that's important to know is it's really like this living, breathing community system. So over the years, the tribal council has become concerned about other behaviors, and they've added them to the system. So you can see there non-suicidal self-injury and binge substance use, while not suicidal in nature, have been added by the tribe to be tracked by this system. The thing that also is really important about the system, before I talk about this holistic approach, is what it does is it does data tracking, right? So if I become aware, for instance, that David was having suicide ideation, I would fill out this initial form. And I could either call or drop it off at the office on the reservation. And then they would start to get numbers to track, right? How many folks were having suicidal thoughts and behaviors. And they would know some basic information about David, right? Maybe like I'd have his gender and the community he lived, and I might have some demographic information on him. And then what would happen is someone from that community who is Native American would come and try to see David at his house and talk to him about what happened. And they would fill out a second form. And that second form would have much more detailed information about kind of the whys and the context. It's really to understand the risk and protective factors. In addition, they would have some good listening skills. And if David really wanted to talk to them about what was going on, they would stay and they would do that. And if he said, well, I'm having trouble getting into the counseling center, they would help him by providing some case management. So the system kind of has this unique data collection component, but then it also has this caring connection to care. And you can see it here. It's really this case management and access to care that these Native paraprofessionals or community health workers are providing through the surveillance system. It then gave us really great data to then design a whole host of programs I don't have time to talk about today, but I'm happy to send some links for some manuscripts if you're interested in reading about those as well. So this holistic approach, not just the surveillance system, but the surveillance system really is the foundation, and then the related programs really allowed us to be able to understand trends in data over time. And it's the tribe's data. We just help them to analyze it. And they have it in real time, which is really nice, because in the US anyway, it takes us a couple of years to have the data publicly available. And maybe you guys are more sophisticated in Hong Kong, but for us, there's often a delay. And for tribal nations, the race is often miscoded too. So when it's this local data, we have a really good sense of the quality of it. And so what you can see here is, I'm going to get my pointer going, hopefully, is that from 2001 to 2006, before this comprehensive model was going into effect, you can see the rates. And this is the White Mountain Apache rate, the community I'm working in, very high, much higher than other rates in the US at that time. And then this 2007 to 2012 period was really when this comprehensive program was really active. And you can see our rate came down dramatically, right? We didn't, you could do a statistically significant test, but just by the eyeball, people were like, that's amazing. And again, there's more work to do. It's not zero. But that showed a lot of promise and got a lot of people interested in the program. We also saw decreases in suicide attempts if you kind of try to draw a straight line through this during the same time. And again, they're small numbers. So, again, it's preliminary information, but really promising. And so this led us to get a National Institutes of Mental Health more rigorous trial. And so there's some information here about that. And that trial also allowed us to work with other tribes in the United States who are interested in implementing that system. So we now have experience in adapting it to other similar but different settings. So really trying to understand the implementation science of disseminating this program, in addition to gathering some rigorous data. So we're really looking at, we're going to have this factorial design. We're actually almost done. We're in the final phases of data collection now, just getting the last bit of our sample is really going to allow us to understand this case management piece that I talked about that's part of the surveillance system. And it's also going to allow us to understand a couple of brief interventions that we designed, one called New Hope and one focused on the elders. So the New Hope, it's really meant to be a brief emergency department-based intervention. And we do it, though, in the community, just because in our tribal nations, the emergency departments are really stretched even thinner than in the general United States. And so it's really this an emergency type intervention around safety planning, getting some coping skills, trying to problem solve any barriers to treatment that the youth might have, really trying to get them connected. So that's that intervention. It really was a Western-based intervention that we adapted for the tribe. Then the second intervention, we really see them as working together, and that's what the study will hopefully let us to see if the two interventions together are very powerful, that's what we would suspect. The second one is really we developed from the ground up with Apache elders, and I am not Native or Apache, but we really just helped facilitate them developing a curriculum. And it's really meant to be focused. They don't even talk about suicide. It's very strengths-based, and it's meant to boost their cultural identity and resilience, which we know can prevent suicide. So the youth in the trial, I won't spend a lot of time on it in the interest because we have lots of other wonderful presenters. This is the complex study design. And again, I'm happy to talk through it with anyone later. But youth are really kind of coming in through this surveillance system. They have multiple visits and multiple randomization points and multiple assessment points. But you can see in the end, we'll be allowed to study the different combinations of the intervention. So, the youth who are just in that surveillance system and case management alone, youth who get just elders in the case management, youth who just get that New Hope safety planning intervention and case management, and then youth who get both. And we'll be able to look at it by age and gender. because we have kind of a big age range, 10 through 24. And then we'll hopefully have a fairly equal distribution of males and females, and because it may differ of who benefits from which intervention most. So the study design will allow us to do that. And we also have some cost effectiveness work. That's how I met and it was working with David that will allow us to understand the cost effectiveness of these interventions. Again, these are just a sense of some of the other partners. We're really building this network of tribes that we're working with. And I think that's something that the tribes have learned over the years. In the past 10, 15 years ago, they all sort of said, well, we want to do our own work. We don't necessarily care about what the other tribes are doing. This is our tribe. This is what we're doing. And I think now there's really been a shift where, yes, they're doing their own things, but they all believe that they can really work together and learn from each other and form these networks to really get ahead in preventing suicide in their communities. And I think that's really a powerful message from this work too. So again, here you can kind of see what we're doing, the technical assistance that we're providing to the tribes. And I'm happy to make these slides available afterwards for folks who are interested in reading the details. And again, no one's flagged me for my time, so hopefully I'm doing well. But just to give you a sense of some of kind of the future things that we're working on with our tribal communities is we're really, as I've said, I'm not from the community. So we're really trying to put forward our tribal partners from the communities to really lead this work. Sorry, you're hearing my dog a little bit this morning, but it's really been wonderful to do that because they really have the solutions themselves. And I think that's what we really want to emphasize too with the community-based work. We are coming in and supporting them and helping them where they can, but we're really leading it. So David might be letting me know that I'm almost out of time. I see his hand raised. And we're really also trying to work on these upstream prevention strengths-based approaches. So it's more culturally congruent for our tribal partners instead of talking about risks and deficits and how their health disparities are so high. It feels much better and like a program they want to be a part in if it's strengths-based. We're really trying to start in early childhood for prevention. We're really trying to use precision medicine kind of approaches, right? There's not a one size fits all. Everyone who's suicidal is not depressed necessarily. So trying to understand which interventions work for which individuals. And really, again, lastly, just trying to learn from implementation science, really about like this work we're doing with different tribal communities and what makes the difference. Is it the tribal mandate that's really important to the system? Is it the number of workers that we have, et cetera? So anyway, I'll end on that note because my dog apparently is telling me the time is up. But it's been lovely to present to you all this morning. I'll go ahead and stop sharing my slides and I'll look forward to your questions at the end.
Thank you so much, Mary. We have open at the bottom a Q&A box, which you should be able to see. So if you have questions at this time, you can put them there. We will have time at 8:30, our time in Hong Kong, and 8:30 on the East Coast to go over these questions in more detail. But please go ahead and start using that Q&A box if you like. We're going to turn next to the Hong Kong side, and we'll have presentations now from our panel from Hong Kong. This is a group that's been working here to address mental health. And I wanted to first I'll introduce all three of you now, just so that we can get started and I won't have to interrupt again. Candice Powell will be our first speaker, and she is the Chief Executive Officer of Mind HK. She's trained as a clinical psychologist at Chinese University of Hong Kong and worked at the New Life Psychiatric Rehabilitation Association, which is one of Hong Kong's largest community mental health NGOs. She's an honorary lecturer at the University of Hong Kong and a fellow of the Hong Kong Psychological Society. She's trained in evidence-based psychological intervention, also in research. So we're really happy to have her tonight. Candice will be followed by Rachel Wong, who's the Assistant Program Manager at Mind HK. And she currently serves as the Assistant Program Manager for the iACT initiative, which she'll be telling us about. Before she joined Mind HK, she worked mostly in global mobility and finances, managing international client accounts. She's responsible for overseeing the development and working with clinical advisors to design the curriculum. So she'll be our second speaker. And then our final speaker from the Hong Kong side will be Dr. Lucy Lord, who is actually an obstetrician, but the founding partner of the Central Health Medical Practice. She's lived in Hong Kong for over 30 years and partners with doctors at the Central Health and the Patient Care Foundation. So the Patient Care Foundation were startup donors for a new mental health charity that worked with Mind HK to launch it and to help improve awareness of mental health through as many programs that we'll be hearing about tonight. So let me just turn it over to our panel, and we'll have Dr. Candice Powell lead off. Go ahead, Candice.
Thank you, David. Thank you for the nice introduction. So I know the time is limited, so I would like to introduce a little bit about our mind work and then go to other panels. So next slide, please. So yes, this is the agenda. So I'm going to introduce My Hong Kong, and then Rachel is going to introduce the iACT program, and then our executive chair, Dr. Lucy Lord, will introduce what are our next steps. Next slide, please. So next slide. Okay, so a little bit about My Hong Kong. We are a charity of 6 years. So we first start with a international mental health conference back in 2016, and actually we had only two volunteers by then, but right now we have like 44 head count of our staff, and then so we are very excited to expand our work in the community. Next slide, please. So our vision is very big. We are here to ensure no one in Hong Kong has to face mental health problem alone. I will always say that, like, as a clinical psychologist, like, of course, if I have a magic wand, I want like everyone to be like happy. However, this is like impossible. So we are here to, like, when someone with mental health problem, like what service that they can access, like what accompany and care that they can have. So this is our vision. Next slide, please. So our target group, mainly there are two groups. So the first group will be the 12 to 65 who are at risk of mental health problem. So we all know that actually mental health problem is very prominent in lifetime. About like 1 in 4 people will have like a mental health problem. However, the majority of people, around like 70%, are suffering from the common mental disorder, which is like depression, anxiety. And among that 70%, another 70% of them are from mild to moderate. However, this group of people have the lower access to the mental health like services. So that's why that we want to focus on these people who are at risk for full-blown mental health issues. And the other group is the general public. Next slide, please. So our work is actually centered based on the building the mental health capital in Hong Kong community via promotion, prevention, training, and early intervention. So we have a lot of like promotional campaigns and anti-stigma campaigns, hopefully to build the awareness of mental health. And we also organize a number of capacity building, including mental health training, one-off mental health 101, mental health first aid, 12-hour course, and other skills training that I will introduce a little bit later. And then hopefully to build the capacity in the community, in school, in the corporate, and also for the frontline workers in non-mental health organization. And we also offer the train a new type of paraprofessionals called wellbeing practitioner to provide the early assessment and intervention for people with the mild to moderate depression, anxiety. And of all these like 3 components, one thing is very important is that like we are backed up by research. So we want to evaluate our program to make sure that like all our program is evidence-based and also is up to the international standard. Next slide, please. So this is our achievement. So I'm not going to all of this, but like we do want to collaborate with different community partners and academia so that to leverage each other's strength to build a better mental health system in Hong Kong. Next slide. So this is what I would say the training part. It is a very important capacity building for the community. So we offer a basic training, hopefully to arouse the interest and awareness of mental health, and then some specific training, for example, to LGBT population, for example, for staff and for students. Next slide, please. And however, we all know that knowledge is not enough. So that's why we also offer the skills-based training, including the mental health first aid, youth mental health first aid, especially right now we are going to expand the youth mental health first aid. We want to have like more people to understand the youth problem. So from a report that that we know that like 1 in 4 like a child and adolescent that in Hong Kong they are having like mental disorder. And also we want to equip like people's skills to take care of themselves, also take care for each other. So this is how we want to build the mental health capital in the community. Next slide, please. So talking about the early intervention and early prevention. So this is the model that we are using, the transdiagnostic model. This is a transdiagnostic staging theory that in the psychiatry, and we all know that actually in the early stage, actually people are having common symptoms or common signs and symptoms, no matter whether later they are developing depression, anxiety, or bipolar. So that's why actually in the early stage is the most important stage that we can do the work. Next slide, please. So that's why back in 2021, we launched the improving access to community therapy, which is named as Youth Wellbeing Practitioner. So this is the a report, a graphic from our Hong Kong Foundation, and then like we are trying to trying to develop the low intensity therapy using ACT, acceptance and commitment therapy. So this is characterized by like we train a new type of practitioner called psychological wellbeing practitioner, and then to train them use a very structured, targeted, evidence-based, manualized like protocol to deliver the therapy to the people with a need. Okay, next slide, please. So here is more about like the service gap that we noticed like throughout these years. For example, the accessibility issues, and then the disseminate issue, how to translate the research into the practice field, and then the capacity issue of the workers, the frontline workers. For example, some youth workers, they are not equipped with relevant skills, and also how to link back the practice to the research to have more knowledge. Next slide, please. So, that's why this is a basic model that we are using in our iACT, and we know that it is very important to like people, they are not seeking help because they are concerned about the cost. They think that they can fix it themselves, and they do not where to seek help. Next slide, please. And that's why our latest initiative is to develop the iACT Service and Research Hub to develop and adapt and localize the international best practice, and then to try it out, evaluate, and disseminate to the community. Next slide, please. So that's all I'm going to talk, and I will pass the time to Rachel.
Great, thank you, Candy. So I'm going to be sharing a bit more about our iACT program. So our iACT program is an initiative from Hong Kong that is aimed to improve access to community therapies. Okay, so we call it iACT for short. What it does is to train wellbeing practitioners to deliver free, early, low-intensity support to individuals who are experiencing mild to moderate mental health problems. These can include like general stress, anxiety, depression, and so on and so forth. So in this slide here, you'll see a diagram, and this is essentially the current programs that we've got. And these two form what we call iACT. So as Candy mentioned, back in 2021, we started off with the youth program, YDP, where we trained 50 practitioners. And then recently, we've now launched the adult version of the service, which is the PWP program, where we have trained another 30 practitioners. So these two combine together to create iACT. So adopting like a similar model to what other step care models have been implemented in the UK and in Australia, our training program consists of like 4 kind of key parts as well. So what it offers our practitioners is the intensive training. All of our practitioners go through assessments, placements, and clinical supervision. So when we launched this program, we had a slot of 50 spaces. We wanted to increase the capacity for mental health support in Hong Kong. So what we wanted to do was invite different people from different backgrounds. They didn't always have to necessarily have a mental health qualification or worked in the mental health field, because what we wanted to do wasn't really to reskill current people within the field. It was to kind of expand that kind of capacity. We were very fortunate that we had a really good response rate. We had over 300 people apply. In the end, we narrowed it down to 51 practitioners, 90% of which are bilingual, whereby they can deliver mental health support to clients in Cantonese and in English. We also have some of our practitioners who are of ethnic minority backgrounds, and they can deliver interventions in their languages as well. So once we did the recruitment for these practitioners, they then went on to do a 120 hours of in-person intensive training. So our program is slightly different from what you might see in the UK and in Australia, whereby our training duration is slightly shorter. However, it is just as intensive and comprehensive. So from this slide, you can see that the training that we offer our practitioners covers actually quite a lot of different aspects. So for example, mental health in Hong Kong. As I said, we're bringing in different people who want to kind of serve the public, want to support more people with mental health problems. And so we needed all of our practitioners to have the same kind of foundation when it comes to delivering this form of support. So giving them the basic information in terms of mental health in Hong Kong, giving them training on what is like evidence-based treatment, what is like safeguarding, giving them training on counseling skills, how to use clinical documentation, risk management, and also delivering interventions online. a big part of our training was also background and theory in ACT, which is acceptance and commitment therapy. One thing that, some of you might know is that whenever, you see step care models from abroad, whether it's UK, Australia, or other places, a lot of the time they do use low intensity CBT. Whereas for us lot here, we have trialed it with ACT because we think that ACT might be a kind of better or more suitable modality for like the Hong Kong culture. So all of our practitioners have to go through these sorts of rigorous training. And then afterwards, they are then placed into different host organizations. Okay. So by doing so, we are allowing our practitioners to go out into the community and serve as many people as possible. For the youth program, we were specifically targeting youth. So clients that were aged 12 to 24. So as you can see here, we have a mix of international schools, ESF schools, local schools, as well as universities, NGOs, and clinics. So whilst our practitioners are at these organizations, then they go on to deliver interventions to clients. They're there at the organizations for around 9 months. So that's after like the intensive training block, and then they have 9 months to kind of build up their skills to kind of advance later on as practitioners, but also to kind of provide that service to clients. So in terms of how it actually works for clients is that, when we started to do this program, what we wanted to do was to add to that capacity. So one thing that we really were very focused on is that besides doing early intervention, we had to match up our practitioners' level of training with the kind of caseload complexities that they were kind of dealing with as well. This is a really important aspect of our program because what we wanted to do was to really implement that step care model, whereby the more qualified individuals, practitioners, such as like clinical psychologists, psychiatrists, them lot can then focus their time and their efforts on the more complex cases. And then practitioners who maybe, have less training, formal training, they can then support those who are on the more mild to moderate end of the spectrum. So what we do here is that all the clients that take part in this program, all of the students that sign up to receive mental health support, all of them have to go through a really rigorous intake assessment. This is really important to determine that suitability. In the event of them not being suitable, then obviously we have support measures in place whereby clients are then referred onwards for the more appropriate mental health support. This can be in the form of host organization support. So for example, if it is a school, then often schools have educational psychologists or school counselors who can then better assist those students. Alternatively, we have external support whereby we can refer the clients to private clinics, hospitals, or integrated community centers for mental wellness, ICCMWs in Hong Kong. But generally, if a client, does the intake assessment and they seem suitable for the program, then they will meet with clients for 8 sessions. They get 8 one-to-one weekly sessions. And during this course of the intervention, where they learn different ACT skills to help manage their negative thoughts, emotions, to help build up that psychological flexibility and also the resilience, the students are also monitored in terms of their progress. So if in the situation that they are found to be no longer suitable for the intervention, then these clients are referred onwards so that they can get that the right support that they need. Otherwise, if they are progressing well within the program itself, then after the 8 sessions, they are then discharged from the program. And generally what we do see is that, those clients that are discharged after 8 sessions, they show really promising signs in terms of their kind of improvements with their mental well-being. So through this program, we actually delivered over 3,300 hours of free mental health support to youth across Hong Kong. Of the many students that took part in this program, we had 417 which finished the complete 8-session intervention. And so from this, we created our kind of research around it, sample size of 417. And the key domains that we looked at were quality of life of clients, psychological flexibility, psychological distress, and also therapeutic alliance. Given that our practitioners were also based at schools, different host organizations, and they had a 9-month placement period, it was a bit hard to kind of do an RCT. So that's why we looked at the pre and post intervention routine outcome measures instead. But also this is due to kind of sometimes the difficulties with getting students to take part in programs or to kind of regularly have their sessions, because in Hong Kong, like with the academic culture here, all the students have really busy schedules as well. And so sometimes it's quite hard to fit in those sessions. But generally, you know, from the data that we've gathered, it's been looking really good. So our preliminary results show that there's improvements in all areas. One thing I do want to kind of point out is that, you know, our findings also reveal that the intervention is most effective for clients aged 18 and above. The recovery rates that we've received are around 70%. These figures align with the results from the UK's Talking Therapies Initiative and also Australia's New Access service. And so what this is, you know, showing is that individuals who take part in this program do often show signs of significant improvement. And so with 6 to 8 sessions, if we can kind of help clients early on to help them manage their kind of negative thoughts, their emotions, build up that resilience, it really does help them in the long run, so that with the skills they learned, if they come across any difficult situations later on, being able to apply those skills, it really does help them to kind of move on and also, you know, build up a kind of more fruitful life in that sense, whereby they can actually, you know, respond to different sorts of stresses in life and all that. So in addition to the quantitative data, we also gathered feedback from schools and also our clients, the students as well. So generally the schools then have said that, you know, it's really useful having the practitioners at school, because one thing that our practitioner offers is psychoeducation as well. So besides giving students these intervention sessions, they go in and do a lot of talks, and generally, you know, creating that awareness around mental health. Often a lot of the times is that, you know, students are so focused on, you know, academic performance and all that, that, you know, they do sometimes kind of pay less attention to their mental health. So now, you know, having that kind of conversation in schools definitely does help, and it does help to reduce some of the stigma as well. In addition, you know, some of the schools have also said it's really important to have practitioners who aren't necessarily school staff or school social workers. Due to some confidentiality concerns, sometimes students aren't willing to reach out. So by having this practitioner at the school, they can really provide mental health support to individuals who might not necessarily be raising up and kind of reaching out for help. And then in terms of clients as well, a lot of the feedback that we received, you know, was that the skills that they learned were really useful. And generally, you know, with practice, these are skills that they can apply in their day-to-day life. And just having more awareness and understanding about their own feelings as well. And so that's kind of one of the key things that, you know, our clients have often said. So the next step, you know, as I mentioned, you know, a lot about our YDP program. Our PWP program is also currently in progress, and our practitioners who are serving adults aged 18 to 65 are currently at host organizations across Hong Kong providing this service to people. So if any of our Hong Kong kind of attendees here are also interested in finding out more, then we can kind of share a link to our website later. But generally, it's like www.iact.hk, where you can find out more about this service. But the next big part of our kind of program itself is the next upcoming training cohort. So we'll be starting to recruit practitioners in October, and then training to start in May 2024. So this will be a new cohort of 50 practitioners who will be serving youth and adults across Hong Kong. And then we aim for service delivery from September. And so generally, that's kind of what the iACT program is and our kind of next steps. But now I'd like to pass to Dr. Lucy Lord, who will then give you more updates and info.
Hi, everybody. Thank you for inviting us, and really impressed with Mary's presentation, and lots of similarities in terms of the community approach to mental health, but also significant differences in what we're dealing with between the two communities. Maybe David, could you how many Americans have we got logged in case is it 30-60, 30-70? Can't do my maths. I'm gonna launch into a kind of context thing in case we have got any Americans who are wondering what we're up to. So the reason we have talked a lot about iACT and early intervention is because we have a real problem with therapists, both psychiatrists, clinical psychologists, and even counselors in Hong Kong, which so we have probably 290 full-time equivalent psychiatrists for 7 million people. I don't know what you have, but for New York, I think the equivalent is nearly 2,000 psychiatrists for 7 million people. Clinical psychologists, we have a tenth of the recommended number by the WHO. Rachel, jump in if I've got my numbers wrong. And counsellors, very difficult because we have no regulatory process for knowing how many we've got. So the biggest problem for Hong Kong, which is very odd for a global city and global financial centre, is an absolute deficit of mental health resources and mental health provision. And so the reason we are talking so much about training new people is this was the only way. In fact, it's a kind of the similarity is that we're training kind of barefoot mental health doctors to make up for the lack of professional mental health intervention that is available. And we don't think Hong Kong is obviously not the only place in Asia that is suffering from this. The reasons other places are suffering are obviously very different. Most of it is economic rather than structural. So we hope in what we have done at Mind Hong Kong doesn't stop at Hong Kong. We hope that what we have done, which is basically take strategies that have been honed in other countries like the UK and Australia, research protocols that have been developed there. We have spent a lot of time developing them to make them fit for purpose in an entirely different cultural setting. So obviously that is the similarity with you guys taking university and kind of cross-cultural things into a different culture and making sure it is fit for purpose and has the support of the community that you're trying to serve. The difference is that you were looking at the very sharp end of suicide prevention. We are actually quite good at that because all of a huge percentage of our resources are hospital-based. So relatively, that's less of a problem. But we have a huge problem in that the early stages of mental health support is really not there. Or if it is there, it's entirely unaffordable for probably 70% of the population. So we hope that, first of all, the research that we've done and the localization of iACT that worked in the UK and worked in Australia, that we've done it in a way that that works in Hong Kong and may well be fit for purpose to work in other countries. The most important thing for us has been scaling up capacity, and we want to do that at as fast as we can. We have used the iACT system in order to produce an ecosystem of very carefully, legally structured and governance structured protocols in order that we can develop it, and it should be fit for purpose to go into other countries and to go into other areas of mental health. So making sure we support the people we've trained in an alumni system, which makes them stay within that system, so that keeping them within that structure so that they continue to be supervised, we can continue to audit them, and most importantly, they continue to provide care at a price point that fits our low-income families. I know that's not quite with the slides. Sorry, guys, I'm not very good at talking to slides, but I hope for those, it may have given a little bit more of a summary of what's different about what we were dealing with in Hong Kong, and how our community approach was at a totally different end of the kind of severity spectrum, but used a lot of the similar must be fit for culturally appropriate interventions. Looking forward, one of the things we are really keen to try is developing training for traditional Chinese medicine practitioners to use some of our iACT or ACT interventions, and see if we can build capacity, not just in Hong Kong, but maybe in China, to really not just address Hong Kong's deficit of resources, but also that in the mainland. So I'm sorry that's not speaking to the slides, but probably Rachel was expecting that anyway. Okay, I think that's it.
Great, thank you very much. We'll be sharing these slides back out later, but if there's any sorts of further follow-up questions that you might want to ask us, then feel free to contact us. Thank you.
Well, thank you much for that presentation, for all of you from Hong Kong. And we have time for questions. Let me see what's popping up in the Q&A box, and I can see some questions here. I have a question from Rebecca Chu, who's asking, are the planning and design of the immediate living environment concerns to you? I think this is for Hong Kong. The housing estates, or perhaps other types of housing, do you see the living environment as an important factor influencing mental well-being and for the healing of mental patients?
Candice, do you want to take that one?
Sure. I think of course, like Hong Kong condition and most of the places, especially for people with like lower SES, they live in a very crowded situation, and some live in divided home, which means that a apartment of like 400 square feet and then divided into rooms, and then their rooms is include like a bed and a bathroom and the kitchen inside. So it's like really like far from ideal like living situation. So we believe that the external factors is affecting mental health. However, at the same time, that the internal factors, for example, like how the person like perceive the issues and how are also affecting the mental health. So that's why that we are using ACT, the acceptance and commitment therapy. So the acceptance part is not about like giving in, but about like acceptance of our inner experience, for example, the unpleasant emotions or the negative thoughts, and at the same time to explore the value such that the individual can really take action based on their value and live in a meaningful life. So I think I do agree that like this external environment is a factor. However, with the situation that we cannot change in a short time, we also like put a lot of emphasis on changing the psychological factors as well.
I think it's super interesting that we're dealing with, absolutely the opposite ends of the space spectrum in this, is that you've got 1.6 million acres and most of our families have got about 110 square feet per person. And yet we're dealing with mental health, which is remarkably consistent in its presentation across cultures and across stressors. so super interesting that, you know, in the end, it is communities that have got to come together to solve this problem.
Lucy, that's a wonderful observation, and it sort of says space alone isn't the part; it's the people, isn't it? It's the interactions and the social life that matters, and how we change that. What I thought was interesting about Mary's presentation was to really be deliberate in using the elders to be part of the social space of youth. And I was wondering if anything in Hong Kong could learn from that. I think a lot of your counselors are not generally elderly, and we have so many people who are getting on in age in Hong Kong. Is that possible here in Hong Kong?
I think we've looked at all sorts of community strengths to see what we can build on. Particularly, we've looked at churches actually do a lot of a lot of counselling for people in distress, and certainly one of the things we have been looking at is to put our adult PWP practitioners, you know, or allow them to go into to be hosted by churches. I think we don't have that same kind of elder kind of influence. I think while we have a lot of respect for our elders, to a certain extent, the elder influence has waned a lot, particularly in Hong Kong, because it's probably the most western bit of China. I think it's probably going to be more useful when we're looking at the situation in the mainland. And I think the most similar approach would be if we do manage to get TCM practitioners trained in an iACT intervention, which I think would be helpful for Hong Kong, but would be transformative for China, given the potential for capacity change. So again, we're looking at absolutely the opposite end of the spectrum in all forms of size. We had a conversation 2 or 3 years ago, probably 2 years ago, actually, with Professor Jha at the Mental Health Center in Guangdong. We were explaining our iACT program, to build barefoot mental health practitioners into the system to make up for the lack of professional resources. And he said, when you finished your pilots in the UK, would you consider setting this up in Guangdong? And I said, yes, we'd love to help you. How big would the pilot be? How many people are you looking after? At which point he said, well, I look after 100 million people. So I was interested with Mary looking at her numbers, and obviously our numbers in Hong Kong are kind of in the mid-range, but the potential for the lack of mental health resources in China is really quite extraordinary. The conversation I had with Professor Jha was that he said, we have no preventive mental health services in China, a tiny amount of private service, but that's it. All health services are basically, the starting point is admission to hospital. There are mental health nurses that then visit villages who are known to have someone who has been admitted with an acute mental health crisis to hospital to make sure they're taking their meds and their follow-up. But there is literally nothing in terms of mild to moderate mental health services. So again, very, very different.
So part of what we saw in both of your presentations was the involvement of the community in solution finding. And I wanted Mary to reflect on, why seniors came up as a solution in the White Mountain Apaches, and why in Hong Kong there was a sense that although seniors are respected, they're not thought to be helpful. Whose idea was it in New Mexico that they would be helpful? Did kids come up with this, or did the seniors say, well, we're going to be good at this? How did it rise up as a solution?
Yeah, that's a great question, David. And I think it came from multiple individuals, but probably not from the kids themselves, which is really, is interesting to kind of think through. So I think we had a couple of things happen. We had elders in the community say, we want to help with this issue. And part of what they actually did, so there was a lot of stigma around suicide when the tribe first wanted to work on this. So as you can imagine, it might have been very stigmatizing to be reported to this community surveillance system for suicidal behavior. And so at the group working on suicide in the community, and again, it's had different stakeholders from different organizations, but youth probably weren't really well represented at the time. They said, we need to have people that are really well respected in the community come out and say, it is okay to talk about suicide, because they didn't even want to use the word. It's really taboo in their culture to even to say the word. And so they had some tribal leaders who are on the tribal council, but then also elders who really are, the wisdom keepers of the cultural knowledge, say, yes, this is taboo. We haven't historically talked about this, but our kids are dying and we need to talk about it. And we are telling you it's okay. So we had elders kind of like do that leadership role in the beginning. So they were kind of involved from the beginning to guide the program, but they also really wanted to help. They said, we are willing to go door to door in our community, which, as you could see by the size, that's possible, right? In some of these tribal communities, we're willing to go door to door and like help these families, or to sit with you in a suicidal crisis. So in our reservation communities, many of them don't have inpatient hospitals. Like this one does not have an inpatient hospital. They have to be flown out by a helicopter to like a main city in Arizona, which, as you can imagine, is a whole nother challenge. But the elders were even like willing to do that. So they've been very involved in the beginning. And then I think the other reason we thought about it is because you'll see in different studies in our community and in other tribal communities that loss of culture, language, a strong native identity of who you are is a real risk factor. And the individuals who have that, it's really protective. And so they've thought that involving the elders would be a good way to work with the youth. It would have connectedness, so strengthen youth connectedness with the elders connect us with the youth, and then hopefully by telling some of those cultural stories and talking about identity, maybe the youth would kind of get some boost there that would prevent suicide or make them stronger. So I think those are some of the reasons. The youth never picked it, but we do hear anecdotally, because the elders also went to the schools. The youth really like look forward to it. You'll see that like chase the elders down in the hallway and they're like, auntie, auntie. And that's, it's like that's a nice familial term for them to use. And they like look forward to when they're coming, that, the teachers are like, the kids behave better in the classrooms after the elders leave. So I think like the kids identify it, but they seem to enjoy it when we've brought the elders into the schools. But I'll pause there. Hopefully that answered your question, David.
Thanks, Mary. I'm going to turn on to the Q&A. I see a question from Polly Wong, who asks, as someone who's lived in both North America and Hong Kong, currently in Hong Kong, the stigma is a real problem, and the work of Mind HK is a real resource and raises awareness. So one of the things that we see people doing is sharing their own personal experience and being open about struggles with mental health. What other things what can ordinary people do in their daily life to help combat stigma?
Actually, I'm feeling we may have been given our elders a bit of a bad rap in Hong Kong, and I'm enthused by Mary's the elders helping, and maybe we should return to that. what we found was the youth has embraced awareness and anti-stigma way more than the elderly. And in fact, rightly or wrongly, the elderly have been hit with the reason why very little progress over the last 30 years in Hong Kong has been made. In other words, the stigma is worst in the elderly population, and certainly that's what we've seen. And whether we should try again with particular groups within the elderly community to see whether we could find a way round that. And I think, Mary, you've given me a bit of A, hope, and B, feeling that, you know, we shouldn't just give up on our elderly in Hong Kong. And I think it would make a huge difference if we could get older people talking about mental health. So in answer to the question, what can everyone do? I think kind of train a granny. Train a granny to embrace and talk about mental health and try and fight the stigma amongst the elderly. We probably shouldn't give up on them.
So, Mary, did you find that some of the elders, I mean, you described some that wanted to get involved, but there must have been some individuals that were stuck in stigma, or maybe I just don't know this community well enough.
Sorry, David, was that for me?
I was asking whether or not, I mean, aren't the elderly a mixed bag? Isn't that what I think?
Yes, just like any group you work with, right? There's sort of a mixed bag, I think. But here the prevalent sentiment is we want to help the youth, and so for us that really was like what got them motivated. Even though some of them were like more comfortable talking about suicide versus others, there's a strong cultural value, and I'm sure in many other cultures as well, where youth are really sacred to them. And so when they were really seeing these spikes of suicide among their young people, and as you can imagine, it's a small, tight-knit community. So they all really, it's like they know everyone that's dying from suicide fairly personally. And so it really, I think impacts them in a way where they feel really motivated to try to help. Even if they're at different levels of readiness, right? But there are definitely some elders that are more hands-on, like we're the ones going in the schools, we're the one teaching the lessons. There's others that are willing to like help in different ways. So you kind of like meet them in their stage of readiness. And then some of those other more influential or outspoken elders sometimes can motivate some change in some of the other elders. So we sort of take them, as they are. And we had an elders council. That was another thing that we did. They really enjoyed that. So like, because it served a couple of purposes, right? Like elders in many places can be isolated, right? And lonely. And so by our team bringing the elders together, they really enjoyed that themselves, that like social component of like, hey, I'm getting to come together once a month with like fellow elders. And this is like we get a meal and we talk about, how we can help the community. And then some of that group would go on and do a lot more of this like outreach, right? But that also is a way we kind of got them engaged, and it served a couple of purposes, right? Because hopefully it boosted the elders themselves, and then it got some of them more willing to be involved in our programming. But yeah, you definitely do get some that they definitely have different opinions. They're not always agreeing on everything. Like when we tried to develop the elders curriculum, where they all had to agree, like, what is it we want to teach as our culture? It was fascinating. I couldn't understand most often speaking in Apache, but I got to be in the room sometimes when this was happening. You could kind of see the debate, but it took like many, many years to get that curriculum developed because there is some of those really big differences in opinion. So hopefully some of those examples are helpful.
Okay, for those of you who are still on our panel, the the Q&A box is open. I'd like to talk about while you're putting your question into the Q&A box, is the role of research. So on both of our examples, research has played a prominent role, and somehow or other you've avoided the unintended consequence of the people feeling like they were simply pawns in a research game. Happens so often. It happens in many other projects where the people see the researchers and they lose trust. So what have you done to avoid that potential pitfall?
Maybe I can help answer this question. I think this is true, especially for a lot of like frontline workers, and we just like ask them to give the questionnaires to the clients, and then a lot of the time the frontline worker will see that as an administrative work, and the client will see that they are just a research subject. So this is not something that we want to do. So what we are trying to do is that we do train our workers, our practitioners to understand what is the rationale of research, and also to highlight the clinical utility of the questionnaire that they completed. For example, they can debrief for example, the depressive or anxiety symptoms in section, so that to help as a client as clinical tools in addition to the research tools, and at the same time to really articulate the rationale of the research is actually not just an administrative work, but help the field to understand the trends and help us to improve the service. So that's how we prepare the workers, and at the same time for the clients as well, to let them know that actually when they fill in the questionnaires, it's help them to understand themselves and also to help them to improve the service. So that's how we are trying to promote the research part. However, like doing youth is like difficult. So we also find that actually a lot of youth are like filling the questionnaires within a very short time with the same questions. So that actually there are a lot of like data that which we are skeptical about the reliability. So I think for this work, we are trying another effort, for example, to fill in the questionnaires together with the youth together. Yeah. So these are some of the ways that we want to highlight the value of research.
I think the other thing, rather brutally, is when you're offered two options, one of which is experimental or under research, then you might well be skeptical of the one that's experimental. I think very brutally in Hong Kong, because of the lack of resources, that they don't have other options. It is pretty much that it's iACT or nothing, which is obviously tricky for us ethically. But I think the research follow-up option is seen as a part and parcel of just getting the therapy. But it's not arduous. It means we can't double blind it. Sorry, we can't randomize control it. But it is, it does mean that people are pretty cooperative. Not the young people who just, some of whom have just been ticking all the D's or all the A's, but the over 18s, I think, have been very good at, from what I understand from the feedback, at actually giving quite responsible answers and in line with what other countries have seen from this kind of intervention.
Thank you. And Mary, any reflections from your side?
Yeah, I mean, I think for us, like we try to really have a mix of what we might call service grants and research grants in the community. And I think that helps. So everything is not necessarily an NIH randomized controlled trial. We have a lot of programs that we bring to the community. So I think that helps with the research. We also have very similar approaches that Lucy and Candice talked about too. I mean, unfortunately, in our tribal communities, they don't have a lot of resources. So a lot of our studies are not just risk and protective factor studies. It's usually providing an intervention or a service. And so they're sometimes happy to participate because they just don't have a lot of other options. But again, that is tricky because you don't want people to feel like they're being coerced because there's not a lot of other options in the community. I think the other thing we do is when we do randomized trials, we don't usually offer nothing, as the other, as the control arm. It's usually like comparing two interventions, or it's a waitlist design where everybody eventually gets the intervention. So we do some things like that. And then it's usually not folks who look like me that aren't from the community doing the research, right? It's usually we have, very well trained Native American staff in the field who are doing the studies, and they believe in it. So that's important. We have to have them believe in it. And then they are more trusted in the community, right? To be the face of the research. And so those are just a few of the things we do, but it does definitely come in waves, where we realize like, gosh, maybe this community feels a little saturated with research right now. We need to like maybe just do more service projects. So it definitely comes in ebbs and flows.
Okay, I don't see any more questions. I would like to ask, I know there are a lot of students that might be on. Last question for me is can students get involved in either of your projects? And if so, how can they be helpful? We have practicum students at the master's level, we have doctoral students, and even undergrads who would like to get involved. Is there opportunity?
Thank you so much for all the interest to get involved in both project in the States and also in Hong Kong as well. So for My Hong Kong, we do need more people to join our workforce. If you're interested, of course, you can be one of our iACT practitioners in the next cohort. And also we do recruit interns and volunteers. And I think that like most importantly is about like you are interested in mental health, you are helping us to spread the word about the anti-stigma and the like how you yourself to prioritize your own mental health. I think this is the most important. If like every one of us is prioritize our own mental health and also to be compassionate and like non-stigmatizing people with like mental health condition, I think this is important. But we also have a lot of events, for example, like More Than a Label and iACT and other trainings that definitely welcome you to join. So please join our newsletter as well, so you will get our latest updates.
Yeah, we don't have any elders, so we just need youth. Unless we can get the elders on the program. Not looking very likely at the moment, but we're going to have another try.
Okay.
I think for us, sometimes we do have students help, from different places. And so for us, it's usually more on the, the research end, because that's easier to do from afar or from being from a different cultural context, maybe with data. So folks really like looking at data or helping sort of with the research part. That's great. In terms of like going to the communities, we're usually a little more cautious about who we send, to our different tribal partners. And they're often, prioritizing Native individuals for like more the on-site placements. But we can all, if you're interested, just reach out and sometimes something might be available.
Well, that's very nice. I'm going to reflect before we close. We've been through this webinar on mental health now for more than an hour. And there weren't any slides, and we've not talked about COVID, and that major hit on our mental health didn't come up. That's wild. It's like the elephant in the room, and we're so traumatized by it that we don't want to talk about it. But it was a huge part of what we're dealing with. I see, Candice, you're applying. You've answered that last question in the Q&A. I really wanted to reach out and thank our audience for coming this extreme hour, and I wanted to thank all of our guests for sharing. I thought we've a lot more connections together, and we've seen how opposite ends of the planet similarities come up, and we can share and learn together. So we close. I just wanted to thank ourselves and remember that anybody can help with combating stigma. Be open, bring this up. Mental health is everybody's business. Well, thanks everybody. Bye-bye. Have a great time. Great
Thanks,
night.
David. Really,
Bye,
really
thanks,
good
everyone.
fun. Thanks, Mary. Lovely to meet you.
Thanks,
Yes,
Mary. Thanks,
everyone.
David.
Come and visit us in Hong Kong.
Sounds good.
Dude.
You're welcome to me as well.
Start again.